I would now like to invite Dr. Johnson Pradeep, Professor and Head of Department of Psychiatry, to speak a few words about Dr. H.S. Subramanyam.
Good morning to all of you. It's indeed a great pleasure to host the third H.S. Subramanyam Memorial Oration at St. John's Medical College. Dr. H.S. Subramanyam, he was a legend of psychiatry, was born on August 28, 1929. So he pursued his medicine and he earned his MBBS degree from Mysore Medical College and later completed his DPM at the All India Institute of Mental Health. Now it is called as NIMHANS. He traveled to England. After that, he returned with 3 membership in the Royal Colleges of Glasgow, Edinburgh, and London. He started the psychiatry department at St. Martha's Hospital, Bangalore. During that time, psychiatry was a much less prioritized and stigmatized subject. But even then, he was instrumental in getting 2 male beds and 1 female bed. He was mainly instrumental in setting up the Department of Psychiatry at St. John's Medical College Hospital. He continued to inspire students in psychiatry. More importantly, his personality and teaching abilities persuaded many of his students to pursue psychiatry as a career. If there are a high proportionate of psychiatrists in Johnites, it's because of the spark that ignited their candle. He quickly realized that the only way to get started was to open a totally psychiatric-centric institute. And it all began in 1964. And it was one of the earliest private establishments of all time. His understanding of medicine, neurology, life experiences, and human touch and love, his experiences, and his strong self-confidence allowed him to perceive the patient's family and society as a whole. His patients adored and admired him all at the same time, since he could be a psychiatrist, a mentor, and a godfather at the same time, and they looked to him for solutions. Dr. Subramanyam married Mrs. H.Y. Kasturi as was a well-known psychologist at the time, and they had 3 children, 2 of whom are psychiatrists, and 1 of them is a cardiac surgeon. Dr. Subramanyam was a well-read and intellectual individual with diverse interests ranging from medicine to music, philosophy, contemporary faiths, and wines to government cuisine. He continued his private practice after retiring in 1988, but spent increasing amount of his time studying philosophy. He died as a proud man who always held his own and inspired respect and love. And I'm very happy to have his son here, Dr. Aditya Subramanyam. I would like to welcome him today. Thank you, Dr. Aditya, for coming for this program. So with this note, I'll hand over to the Dr. Swati.
Thank you, sir, for your wonderful introduction of Dr. H.S. Subramanyam. His life is indeed something which is inspiring and we all aspire to be. The chair for today's session, Dr. Matthew Verghese, needs no introduction. A proud Johnite of the batch 1975, Dr. Matthew Verghese started his career as a psychiatrist at NIMHANS in 1984. During his illustrious career of more than 3 decades, he held multiple leadership posts such as in charge of Family Counseling Center, head of Department of Psychiatry from 2013 to 2016, and superannuated in the year of 2021 after serving as the head of Geriatric Psychiatry for 5 years. His contribution to the field of psychiatry research is vast with multiple projects and more than 200 publications. Prominent among them being World Mental Health Survey of 2006, National Mental Health Survey 2016 and 2022, Longitudinal Aging Study of India 2020-2022, Dementia India Report 2010, Dementia in India 2020. Despite being an executive member of multiple academic and scientific boards, he still has the zeal to work as an adjunct professor in Department of Psychiatry, heading the Geriatric Psychiatry Division at St. John's Medical College and KMC Manipal. We are indeed honored to have you here, sir. I now request Dr. Matthew Verghese to come to the dais to introduce the speaker of today's session, Dr. Somnath Chatterjee.
Thank you very much, Swati. And it's good to be standing here to introduce my former colleague and friend, Somnath Chatterjee. First of all, I must thank Somnath for agreeing to do this oration rather last minute when I asked him just about 2 weeks ago, because the former speaker was not able to come. And so I knew that Somnath can just get up from his sleep and start talking. So Somnath and I go way back. Somnath is a batch of 72, 73, and many of the classmates are sitting here. Batch of 75, 2 years younger than that. We were the batches who were constantly fighting with each other for various talent contests, sports, and so many things. But many years later, our paths met when we all joined NIMHANS. So from Somnath's batch, actually Somnath's batch with Somnath, Ajit, D. Sanjeev, Vidyasagar, and Mary Naidu, they probably have the, and a few other people, I think almost 7, 8 people, they have probably the largest batch of people who became psychiatrists. And I think some of the first senior officers in the Department of Psychiatry with Dr. H.S. Subramanyam, and I think in those days Prakash Appaya and then Tanya, I think, joined soon after. They probably Tanya. So I think they were some of the first SHOs in the Department of Psychiatry. That time, Department of Psychiatry was at St. Martha's, and then later on, sort of we moved here. And later, when I joined NIMHANS in '81, Somnath was there. Somnath, Ajit, and all that whole batch was there. So they were like, again, 2 years senior to us. And then we continued our contact there. Now, Somnath is very quiet, and some people said, oh, we don't know who Somnath is. So Somnath has actually done a lot of things in the field of psychiatry. I'm not going to read through his large, more than 1-page CV, but right at NIMHANS, in the days that we were there, he was actually responsible for doing many of the interview schedules in psychiatry. So earlier on, the present state examination, and then later on, the computerization of the schedule for clinical assessment in neuropsychiatry. In fact, the computerization of the scan was done in those days by computers in Bangalore at NIMHANS. He also worked on the WHO disability assessment schedule, and he was a member of the Worldwide Classification of Diseases, the ICD, and also the ICIF, so the International Classification of Functioning, Disability, and Health. At NIMHANS, he was one of the first people to start the sleep lab for mental disorders and the molecular genetics lab for complex diseases. He left NIMHANS in 2000 and went off to the WHO, and he spent almost 25 years at the WHO. And he's just come back just last year, and he retired as the outgoing director of the Department of Data and Analytics and the senior advisor to the Division of Data Analytics and Delivery for Impact. So during the time that he was in WHO for more than 25 years, he coordinated various international projects, including the development of the, I already mentioned the ICF, the revision of the International Classification of Diseases, the ICD. He was, together with Ron Kessler and other people from WHO, he was actually spearheading the World Mental Health Surveys and the World Health Surveys. The WHO study on global aging, all of you know the SAGE study, which is a cohort of more than 45,000 persons in 6 countries. And the SAGE actually in some ways preceded the LASI, the longitudinal aging study of India in India. So World Mental Health Survey, as all of you know, is one of the most prestigious studies which have been there in over 30 countries, and many other initiatives, all from the National Institute of Mental Health and the National Institute of Alcoholism, and the National Institute of Drug Abuse and the National Institute of Aging in the US. He has contributed to various editions of the WHO's health statistics and global monitoring reports on the universal health coverage, as well as the World Report on Disability and the World Report on Aging and Health. He worked on improving the measurement of health trends and their determinants, as well as developing standards for data generation, such as establishing various surveys across themes and specific populations with a focus on older individuals. He has coordinated various multi-country research on older persons, and have looked at the health outcomes and trends, subjective well-being and its causes. He has a publication track record of assessing the global impact and burden of health diseases, including works on the burden of mental disorders. He has over 200 publications in prominent peer-reviewed journals, and has been named by the Web of Science as one of the world's most cited researchers. So 0.1% of research community among the top 100 scholars globally in his domain of specialization. So an H index of many times, many of us, he's got an H index of about 100 with all his publications. So I introduce to you Dr. Somnath Chatterjee.
At the back. Thank you. Thank you, Matthew, for those very kind words. You don't hear me? This problem is real. Okay, thank you very much for this very. Thanks once again.
1 second.
Sit. Well, things never go according to plan, right? So, do you hear me at the back? Okay, finally. Thank you very much, and thanks very much, Matthew, for those very kind words. And add that Aditya is here as well. Just to give you a bit of the background, I mean, you can forget what Matthew really said, but we stand on the shoulder of giants, right? And one of those giants was Dr. Subramanyam, who I had the privilege of working with many, many years ago. And I see many of my classmates and many who I don't recognize. And Matthew, as he told you, was 2 years my junior, which tells you how old I am, right? And that's why my interest in sort of how we age, how our mental health changes over time, and hope to make the case that why this matters. Unfortunately, I won't be standing there because I hate to stand behind a lectern. So I will ask Johnson to kindly move the slides for me. So as Matthew said, I began my psychiatric career here with Dr. Subramanyam and many colleagues there. And as you also heard, our batch really had the largest number of psychiatrists who took up that profession. And people knew we were crazy, but this was, I think, sort of convincing people that our batch really needed to heal itself. Then I went on to work at NIMHANS, and somewhere along the way, though I began actually my work in biological psychiatry, I decided to move into the area of public mental health. And I'll tell you why. So if I can have the next slide. So what I intend to talk about is to convince you that we need a radical rethink of public mental health and why there is this intersection between mental health, aging, and disability, what I call madness in the 21st century, because I believe that this intersection is really the next public health challenge of the world, not just in high-income countries, but also in low-resource settings. So I'll talk to you a little bit about a shift in thinking in mental health. Typically, those of us who have worked in psychiatry think about mental health. Do we call it mental health? Really, our focus is on mental disorders, right? And understandably so, because, you know, we are trained clinicians, so we focus on, you know, perhaps serious mental disorders, sometimes on common mental disorders, and see how to alleviate individual suffering. However, increasingly, you would have seen writing about and why mental health actually matters. Now, mental health, you must understand, is not merely the occurrence of mental disorders or the negative side of, you know, having a mental disorder. However, mental health, you know, actually is a very major determinant of chronic disease outcomes and actually of population well-being. Which brings me to talking about, you know, this construct of subjective well-being. Again, you would have heard this sort of term being bandied about, and however, for the purposes of measurement and intervention, we really need to be very precise about what we mean. These are not really interchangeable terms. Subjective well-being is essentially, it consists of three constructs, right? Your affective experienced well-being, your evaluative well-being, that is how you evaluate your life, and in addition to that, perhaps the way you actually look at your meaning in life. Let's leave that last construct out for the time being, but your affective and evaluative well-being actually have a big impact on your life. And you would have again seen, you know, this whole sort of work by, you know, Martin Sen and colleagues talking about going beyond GDP. So in terms of measuring the economic well-being of a country, you need to not just look at, you know, the way the GDP grows, and you would have seen a lot of writing in this country about, you know, what's happening with our GDP, but nobody seems to talk about, you know, what's happening to the subjective well-being of our population and what is happening, you know, to our development in terms of going beyond GDP. Because our human capital depends not just on, you know, how quickly or how large our economic growth is. And finally, you know, you would have heard, with regard to the area of mental health, a lot of writing about the quality of life. In fact, the term quality of life is essentially synonymous with what we call as evaluative well-being, or your life satisfaction. And you would have again seen many reports produced by, you know, Jeff Sachs and others about, you know, the World Happiness Report. Again, the term happiness tends to get sort of kind of muddled with understanding really people's subjective well-being. So this instantaneous sort of well-being, or how much time a population spends being in a negative state of mind. And you will have seen that these trends over time also tend to matter, right? Because there are many, many determinants of those trends which we actually can change, which we can actually intervene with. Have the next slide, please. So let's look at what do we mean by aging and the age-related health conditions and comorbidity. Now, typically, we think of aging as people my age, right? But what you need to understand is aging is a phenomenon which begins at birth, if not before that, right? And those early influences actually have a big impact on your later life, both your physical and your mental health. So there is a window of opportunity to intervene in that early part of life to actually influence late life outcomes. In fact, many people would argue that it's the first 5 years of your life that actually determine 80% of the burden in older age groups, right? Similarly, those childhood adversities have a big impact on mental health. So we keep talking about, aging as if, we can just set this aside till a person is 65 years old, or maybe even later, and then suddenly wake up to this idea. And age-related health conditions, as I said, have sort of changed over time, and typically age-related health conditions usually are chronic, right? So they last over many, many years, and actually cost the health system perhaps far more than acute conditions. Now, acute conditions kill, but chronic conditions disable, right? And the other thing one needs to understand is as people grow older, they often have more than one illness, right? And that more than one illness tends to end up, requiring a person, or actually leading to a person going from, physician to physician and having a very siloed healthcare, right? And that often leads to underdiagnosis, conditions being missed, inadequate treatment, and more so when there is a comorbidity between physical and mental health conditions, that actually produces the worst health outcome and often leads to problems with diagnosis and compliance. Have the next slide. The other thing we need to understand is what do we mean by the term disability? The term disability, again, tends to be misconstrued as a mark of a minority of people, right? I mean, if you look at this country, our censuses repeatedly talk about how, maybe 1 to 2% of our population is disabled. Now that is highly misleading because there is no way we can mainstream disability in the public health agenda if we construe it as simply the mark of a minority of people. And then, on top of that, we don't recognize that it is this disability that actually produces the largest public health burden, right? So disability needs to be understood as a detriment in health state that plays out in your real world, right? So it is the outcome of an interaction between what happens because of your health and how that is influenced with your real world environment, which means the interventions are really should be intended to maximize the functioning of a person in their real world. So when we talk about interventions for disability, or what typically would be called rehabilitation, once again, rehabilitation is not something that is required only for chronic illnesses or only when a person, has sort of gone through the whole rigmarole, of acute health interventions. So rehabilitation is really the method to maximize an individual's functioning, both by changing the body, or what we typically call interventions, whose primary intent is to improve health, or through changing the environment to enable people to engage in the things that matter to them most. And often our focus as clinicians tends to be forward, and we ignore what happens in the person's real world. Can I have the next slide? So as I said, we have to think about mental health, aging, and disability differently, because all these three things are part of the human condition, right? So there are very few mental health conditions which are really qualitatively different from the experience of all of us, right? So that means, again, like disability, this is a universal human experience and often a matter of quantity on a continuum and not a matter of kind. So which means, as the disability community would argue, nothing about us without us, right? So in other words, we are all in this together. And for all these three areas of public health, there is a major role that the environment plays. And if you think of a person in isolation of their environment, you're never going to get the health gains or an increase in functioning that is required. So the way to maximize population health is really to alter that trajectory of disability, aging, and mental health. Because if you wait till the person becomes severely ill, that is actually not going to get you the public health benefit or population health gain that you need. So it's not a cost-effective strategy, right? I mean, I know that all of us have trained as clinicians, but from a programmatic point of view or a policy point of view, you're not going to get the population health gains that you need. If you look at the costs of healthcare, about 80% of healthcare costs happen in the last 1 year of life, right? And that seems kind of a waste of resources, right? Whereas if you were to be able to keep your population healthy for longer periods of time at a much more cost-effective way, you would actually postpone those costs further down the road. And most importantly, I think, what matters to people is, can they engage in the things they want to do, right? That's what causes, to use a shortcut, happiness. And if you ask anybody, what would they maximize? They would choose to maximize their well-being. Now, maximizing health is a means to maximizing the well-being. But ultimately, I think people value, what they can and cannot do in their real world, because that's what produces their well-being. Can I have change? So what is driving this, right? What is driving this intersection? Over the years, right, the population has been rapidly aging, life expectancies have increased, and hence the burden of illness is also changing. There has also been a change in people's lifestyles, change in diets, and as a result, and of course in climate change. And what is happening as a result is that the burden of illness is shifting from infectious diseases to non-communicable diseases or lifestyle-related diseases worldwide, right? So this is not a phenomenon as we typically think of, the rich world, right? So these are not diseases of affluence, right? So already, if you look at mortality trends worldwide, the largest killers are actually non-communicable diseases. And the largest burden of health is happening because of these chronic conditions, with depression actually being the #1 disabling condition in the world in terms of the disability it causes. There are, of course, other commoner conditions. So therefore, at the population level, you have a larger burden being produced by conditions like low back pain, also a lifestyle condition, or other similar illnesses. The risk burden also has been shifting, which is creating this perfect storm. So people are getting older, they are living longer, they are engaging in poor lifestyles, and the mental health impact of a whole host of things is worsening. And as a result, you have this situation where there is this intersection of mental health, aging, and disability, and it's about time that we took notice of this. If we don't do this now, we will never be ready, right? Because countries have often gotten richer before they got older, but they haven't prepared themselves. Their health systems haven't been prepared to be not siloed and to care for in an integrated manner. At the next slide, please. So mental disorders, as I said, are the leading cause of years lived with disability. Between 18 to 35% of the world's population will have a mental disorder in their lifetime, and if one lives till the age of 75, which is highly likely these days, about half the world's population will have a diagnosable mental disorder, right? So again, this is not some trivial thing that you wake up from the wrong side of the bed, right? So you actually will have a mental disorder. I mean, 1 in 2 people in the world will have a mental disorder if they live long enough. Mental disorders are also the leading cause of loss of productivity and loss of human capital. So if you don't invest in your population, when it should be done, you are going to actually have, you'll have a population that is going to be not productive. For example, if you look at the leading cause of days out of role, which means, let's say for the working population, the number of days you don't go to work, the number one cause is mental disorders, right? And in turn, that leads to a loss of human capital. So mental disorders, much like chronic illnesses, often go unrecognized and undertreated. So if you look at anywhere in the world, right, it's only, if you're lucky, 1 in 3 people who have a mental disorder who actually get what we would call minimally adequate treatment, right? So this is because, and this is in the countries with high incomes, with functioning health systems, and so on. In our country, it's probably in the range of 1 in 8 people, right? So these are people who've gone and visited a health professional. They've been recognized to have a mental health condition, and yet they don't meet the minimum standards for treatment. Can I have the next slide, please? Many of you who have been in this space would recognize, this whole debate around, are we aging healthier? And the evidence actually suggests that that is not the case. So in other words, if you look at, subsequent cohorts, that it's not likely, because the case that has been made in the West is that, we don't have to think so much about, physical health conditions, we don't have to worry about aging, because people are living longer and they're aging better. But the evidence actually tends to suggest that subsequent cohorts actually are not aging better, and if at all they are aging better, it is only the rich, right? And even that is under question, because if you look at the baby boomer generation in the US or in the West, the baby boomer generation is actually in much worse health than their parents or grandparents. And they are going to be the next generation that is going to produce the health burden on health system. And as I've already mentioned, the comorbidity between physical and mental health conditions actually produces the worst health outcome. So if you have depression, which is already a disabling condition, and combined with that, you have, let's say, diabetes or heart disease or, stroke. Those conditions now, this comorbidity actually produces a decrement in your health, which is 3 times at least as worse as one of those conditions alone. And the other problem with that is, of course, if you go to a physician, and you're diagnosed as depression, they're not going to look at you again, right? They're not going to look at your physical health conditions, and as a result, it will lead to not just misdiagnosis, but under-treatment of your physical health conditions. So it's really imperative that people understand that as populations age, that they are, or even in the middle age population, that these things are the rule rather than the exception, and hence under treatment. If you look at hypertension, one would think, that hypertension, the first thing a physician does is, when you go to see a physician, is to take your blood pressure, right? And yet, in this country, only 10% of the population who is diagnosed with hypertension or detected to hypertension actually has controlled blood pressure. Now, for an intervention which is probably cheaper than a cup of coffee, it's absurd that this is the case. And why? Because we simply don't educate people. And this is actually the intersection between a person's mental health and a chronic illness. Because chronic diseases require compliance, require adherence to treatment, and require lifestyle change. Now, if you don't focus on that and just simply prescribe a pill, it's not going to happen. The other, big sort of term, which has become very popular and fashionable, I guess, these days, is the term loneliness. Now, why actually it's not just fashionable, loneliness actually matters. And as populations age, as our social networks shrink, and as we are not able to do the kinds of things we would like to do or we were doing earlier, that actually leads to loneliness, social isolation, and then has an impact on well-being. Now, one would think that, this is such a vague notion, your subjective well-being or your life satisfaction. But actually, your subjective well-being is a predictor of early mortality, of premature mortality, right? Loneliness is a predictor of premature mortality. So unless you create the circumstances for people to be able to do the kind of things they want to do, you're actually not going to make a difference by just prescribing, some medication. So it's really critical for policymakers to understand that you can't address this oncoming, what I call the perfect storm of mental health, aging, and disability unless you think about it in a much more holistic manner. Have the next slide, please. So with regard to disability, there are about, our estimates suggest that there are at least 1 billion people living in this world. So 1 in 15 people, 15% of the world's population has a significant disability, right? As a result, once the interventions for disability cannot be, some intervention which is just providing a hearing aid or a wheelchair, right? Or just some assistive technologies. One needs to think about how do we mainstream disability in the public health discourse. In many countries, disability remains on the fringe and is not even the domain of the health system. So again, it cannot be that disability is just addressed as some fringe element and dealt with through, a non-health system approach. Our estimates also seem to suggest that there are about 2.25 billion people who are in need of rehab. And who runs the rehabilitation councils and the social security mechanism? Not the health system. In fact, the health system doesn't even advocate for it. So, have the next slide. So what are the cross-cutting issues, where these things intersect? All these 3 areas, lead to stigmatization. All these 3 areas require an early detection to change the trajectory of these things. They require scaling interventions because these bespoke interventions are never going to reach the masses, right? So one has to think of a completely different strategy of how we scale these interventions from the clinic to the population. Also, the most vulnerable populations are these, right? So increasingly, if you don't address these challenges, you're going to increase inequalities in the world. We talk about universal health coverage and leaving no one behind, but these strategies are not going to work if once again we deal with it in a siloed manner. And we need to have health interventions which are evidence-based, because again, many of our policies and programs are not data-driven, and we don't track the impact of those interventions. Evidence-based medicine, again, has become sort of restricted to the clinic. But you need to make the case to a policymaker why investing in these areas actually makes sense in terms of their return on investment. The next slide. So I think the way to go is to actually look at, first of all, integrated people-centered care. Not necessarily just person-centered care, but really think about how do we engage the population and provide care which is not siloed and not isolated, and we actually provide holistic care to the population as it ages. As I've already talked about, we need really a commitment to universal health coverage. It's not about just paying lip service. It's not about just identifying a list of health conditions that are in some list. It's not about just people who are below a certain income level, but it's really about providing health interventions to everyone who needs it without having to incur catastrophic health spending. With the current technologies, we can identify actually who is at most risk. So we also allocate our resources appropriately. Today, we have the technologies to identify for mental health conditions, for people with, who are aging, who is the most likely to be, let's say, in the top 10, 20% of risk, so that we identify those people early and intervene early so that we don't end up with that disease burden. For example, if you look at people who are growing old and falling, we can today identify who's at most risk for falls, and we can actually intervene with, for example, exercise training and strength training to prevent those falls, not wait till a person ends up with a hip fracture and having to go and get that hip replaced. We also have the digital technologies to actually predict future outcomes. So we can do predictive analytics. We can actually scale interventions. We can nudge people in the right direction to change their behaviors. And our vision really ought to be towards a precision public health, so that we segment the population, we identify who's at most risk, we identify who's most likely to benefit from interventions, and track population health over time. Next slide, please. So as I've been saying, I firmly believe that this is the next public health challenge of the 21st century. It already is upon us. We clearly have a mismatch between the need and the availability of interventions. We need to actually correct that mismatch, and the time to act is now. Thank you.
Thank you very much, Somnath. I think this is something which is not just pertinent to mental health, but I think it's pertinent to all of healthcare in terms of how, for example, St. John's is going to think about what we're going to do with regard to public health and prevention of diseases. I think there are no questions after an oration, so we will go on with the... Thank you very much, Somnath. Thank you for agreeing to give this talk. Thank you.
Thank you. Thank you, sir. It was a wonderful speech, and it was very inspiring for the young generation of psychiatrists and also other professionals, especially public health and community professionals, to take up the points which you started. I hope in the future we can make a change. Now I would like to call Father John Verghese to come to the stage. I would request Dr. Dean to Dr. George D'Souza to come to the stage. Dr. Aditya, can you please come to the stage?
Thank you, sir, for your enlightening session. I kindly request Dr. Aditya to felicitate our speaker. I now request Dr. Johnson Pradeep to give a token of appreciation to our dignitaries. I now request Reverend Father John, Associate Director, Hospital, to give a plaque to our speaker, Dr. Somnath Chatterjee, as a token of appreciation. I now request Reverend Father John to felicitate our chairperson, Dr. Matthew Verghese. I now request our Dean, Dr. George D'Souza, to give a token of appreciation to our chairperson, Dr. Matthew. I now request Dr. Johnson Pradeep to give a token of appreciation to Dr. George D'Souza, Dean of St. John's Medical College, Dr. Aditya Subramanyam, and Reverend Father John. I now request Dr. Johnson Pradeep to give the vote of thanks.
I would like to thank Father John Verghese for making his time for our program. The whole idea was suggested by Dr. George D'Souza for this program. I would like to thank him for giving us an opportunity in the Diamond Jubilee to have this oration. It was a great pleasure, sir. Thank you very much. I would like to thank today's speaker, Dr. Somnath Chatterjee. Despite a short notice, he was able to assemble all the points and he was able to deliver a great lecture, oration. I would like to thank you again, sir, for making your time here and giving your valuable insights. I would like to also thank Dr. Matthew Verghese, who was the main person who was able to identify a Johnite who was in the field of psychiatry and also worked in WHO immediately and was able to get him for this oration. I would like to really thank you for this, sir. I would like to thank Dr. Aditya Subramanyam for being able to come for this oration. It is indeed a great pleasure to have you here, sir. Thank you. I would like to thank the Department of Psychiatry, each and every member who contributed to this oration, especially my secretaries, Mrs. Maheshwari, Teresa Catherine, and Radhika. I would also like to thank Dr. Swati Chandramouli for doing the emceeing. I'm also very happy to have our senior psychiatry members for coming for this program, and also all the alumni, faculty who were able to come for this oration. It's indeed a great pleasure for me to have all of you, and I would like to thank all of you for coming for this program. Thank you very much. After this, we are going to have the third PG alumni meet in Department of Psychiatry. You're all free, all are welcome to join for this program. And I would like to request all the senior faculty of St. John's and alumni of St. John's to please join us for the third alumni meet. Thank you.